Hi, everyone. My name is Barb O'Rourke, and I am a clinical staff and research nurse at the NICU at Blank Children's Hospital in Des Moines, Iowa. I want to thank you all for taking the time to listen today, and I also want to say how grateful I am to the Dr. Brown Company for organizing this webinar. Just a quick disclaimer. As a bedside nurse, I have had the privilege of working with some of the most caring and wonderful doctors, nurses, and therapists in our profession. Together, we share the responsibility of caring for the smallest and most fragile of infants. As the years go by, your experiences mold you, and sometimes you become a little set in your ways. Today, I want to share how one moment changed us and how we care for our infants. That moment drove us to reach out to multiple experts in the field of feeding premature infants, including Christy Fuller, Aaron Ross, and Catherine Shaker. They were all so gracious and willing to listen to us. We are forever grateful for their encouragement. So let's get started. Today we have 3 learner objectives. They are name 2 examples of normal NICU care that may have a negative impact on oral feeding. Secondly, list 1 major developmental reason why premature infants are at increased risk when they receive negative oral experiences. And third, describe 1 reason why oral care may not be enjoyable to premature infants. I have no conflict of interest to declare. So let me tell you how this all started. 5 years ago, I was assigned to take care of a 27-week infant. We'll call her Lily. Lily was a rowdy baby, and as I finished her cares and nested her in, I placed a drop of her mother's milk on her lips. As she pulled her little hands closer to her face, she sucked stronger and longer. Her mother smiled and cried all at the same time. I did not take care of Lily again until the night before her scheduled G-tube, now at 42 weeks. She had become severely aversive. However, there didn't seem to be a reason. No history of reflux, no vocal cord paralysis, no milk allergies, no aspiration, nothing. Her mother had stayed every night and kangarooed her daily for hours. Now, 15 weeks later, as I nested Lily in, I again placed a drop of her mother's milk on her lips. The response was so different. Instead of the ecstasy of the smell and taste of her mother's milk, she now puckered her lips and pulled her head back. The space of time from that first encounter made this such a stark contrast. This was that moment. What happened? That moment brought the concern of oral aversion and the inability of many of our micro-preemies to take full oral feedings at 40 to 44 weeks to the forefront. Our research committee conducted a literature search which provided the evidence that giving breast milk drops orally was not only safe, but provided a level of immunity for these premature infants. However, we did not find any research regarding giving breast milk drops consistently for oral enjoyment. Our IRB approved the project of giving milk drops to our NICU infants with CARES and gavage feedings. Our research committee sought the guidance of our medical team, which includes 7 neonatologists and 12 nurse practitioners. Our unit is a 44-bed, level 3 NICU with private rooms. We presented the rationale of our study, and not only did the medical team agree to our project, but requested that we focus on 23-week to 33 plus 6-week gestational age infants and that the protocol become a standard of care. A quasi-experimental design was developed. The control infants were infants who were discharged prior to the milk drop research being started. The convenient subjects were infants born at 23 to 33 plus 6 weeks after the study was initiated. The control and subject infants were randomly matched by gestational age and gender alone. There were no exclusions per the medical team's request. Our hypothesis was simple. The infants who received milk drops with cares and gavage feedings would have a shorter length of stay than infants who had not received milk drops. Expenses for this project were minimal. Breast milk was provided by mothers or donor milk was given. Our data collectors were our staff nurses. Our champions were our team leaders, so someone was always available to address concerns. The education for our nurses included a mandatory net learning. We had meetings to answer questions, and then we also had email updates. On admission, the parents were given a brochure to explain the rationale in the milk drop intervention. It was produced in English and Spanish, but we also had translators available as needed. They were also given 2 cent hearts to wear and bring back to lay by their infant's face. The intervention would start on the 3rd day of life until the infant was discharged. Milk drops would be offered with every set of cares or gavage feeding. The volume of milk drops was limited by the infant's corrected gestational age or status, and the amount received was based on the infant's response. So let's take a quick look at this volume chart. The first column talks about corrected gestational age or status. So let's just first talk about the gestational age. You can see the 24 to 26 weekers could have up to 4 drops of milk. The 27 to 28 weekers could have up to 0.1 ml of milk drops, and so forth and so on. So again, what this means is the volume was limited for these gestational ages, but the actual amount of the milk drops received was based solely on the infant's response. The third column speaks to intake. Since the amount of milk drops received was so variable, the medical team did not count the milk drops as measurable intake. Now, I want to go back to that first column and point out the status of being NPO. For this infant population, at one time or another during their hospital stay, this would not be an unusual status. If an infant was made NPO, the doctor would determine if the infant could receive their milk drops, and he would write an order regarding that. However, if the infant could not receive milk drops, we would simply document this, and when feedings were restarted, so were the milk drops. These infants did remain in the study. Data was collected with every intervention. Physiological data, including heart rate, respirations, oxygenation, the infant's state and tone, were documented before, during, and after the intervention to assess the safety of giving milk drops. And the nurses also documented the infant's response to the milk drops. This was double charting for our nurses, and they did a great job, and we are so grateful to them. So that was a lot of background information. So let's start talking about the milk drop intervention itself. First, we'll go over the rationale of giving milk drops. We'll talk about the research and evidence that discusses the safety of giving milk drops. We'll also look at the results of our research, and we'll watch a few sweet videos of these tiny infants taking milk drops. And we'll have time for questions too. Before I was born, I used all of my senses. I would taste and swallow the amniotic fluid. This fluid has the scent of my mother. I would touch my face and my mother holds me. I could see light, and I usually fall asleep as I listen to my mother's heartbeat. Then everything changed. Strong smells, bright lights. My skin is dry. I feel so weak. Where are my hands? My mouth is a war zone. Tubes, suction, oral care. I miss my mother, her touch, her scent, her taste, her sounds. The very low birth weight infant has a survival rate greater than 85%. An estimated 50 to 70% of these infants will have later dysfunction, including cognitive, behavioral, and social delays. 80% of premature infants will have difficulty with feeding, now the leading developmental issue. In utero, the feeding process begins. The developing fetus begins to suck around 15 to 16 weeks. Swallowing is also developing around the same time at 14 to 17 weeks. Swallowing is a complicated process involving 26 muscles and 6 major nerves. The coordination of suck, swallow, and breathe begins to evolve around 31 to 33 weeks and really only matures around 37 to 38 weeks. This developmental process does not stop when the infant is born. However, the necessity of normal NICU care, including suctioning, tubes, taping, and even oral care, may have a negative effect on the infant's ability and desire to eat. A major reason for the increased risk is the structural differentiation of the brain is occurring rapidly between 23 and 32 weeks gestation. Over 100 billion neurons are being organized and connected into networks and systems. Most of us have seen this chart of the infant's brain as they're developing, but it is always an important reminder of how vulnerable these infants are. It is so interesting to see that the 25-week brain is basically smooth as compared to the full-term infant's brain. So much neurodevelopment is being completed in these last final 15 weeks. The development of neural networks depends on molecular cues and activity. The more frequently a neural connection is stimulated, whether good or bad, the more likely it will become permanent. However, neural connections that are not reinforced by experience may become lost. In other words, if the infant receives more negative oral experiences than positive oral experiences, the negative may become dominant and the positive connections to oral enjoyment may become lost. There are neuroprotective interventions that we can do to support the developing brain, promote normal development, and prevent disabilities. Nutrition is important for neuronal and glial cell growth and development. As the rate of weight increases, the risk of poor developmental outcome decreases. Breast milk has the optimal nutrient composition. It has been found that infants who receive breast milk have greater white matter and brain volume and fewer neurodevelopmental disabilities. Another way to protect our infants is to control the environment. We can turn down the lights, decrease the activity, decrease the noise. And developmentally, there are many things we are already doing. We give the infants boundaries and swaddle them for comfort, security, and flexion. We place them in isolettes to protect their sleep and to decrease noise, light, and drafts. We offer them pacifiers for non-nutritive sucking. And socially, we spend time with the infant, holding, touching, and speaking softly to them. Another neuroprotective intervention is Kangaroo Care. The infant lays skin to skin, listening to his mother's heartbeat, feeling her comforting touch, smelling her familiar scent. Kangaroo Care has been found to stabilize heart rates, improve oxygenation, decrease crying, increase sleep time, improve parent bonding, increase success with breastfeeding, and often earlier discharged home. So, what has this all to do really with oral enjoyment and feeding? The National Association of Neonatal Nurses states, oral feeding preparation begins at birth. Our job is to ensure every feeding experience is a positive, pleasant, and nurturing time, regardless of size or age or route or volume of feeding. However, if oral feeding preparation starts at birth, but oral attempts are only offered at 32 to 34 weeks, is there a piece missing to this puzzle? For the infant born at 23 weeks, that is 9 to 11 weeks of suctioning, tubes, taping, oral care, and even just pacifiers during the most critical time of structural differentiation of the brain. And yes, if this little one was still in his mother's womb, he would be licking, tasting, sucking, and swallowing. So what we do know is the brain does have the ability to change. This process called neuroplasticity is affected by experiences, and all experiences are filtered through the senses. Now, how can we harness this knowledge? By doing what we already do, but adding an enjoyable oral component. We will do it deliberately and consistently around the clock with cares and gavage feedings to provide a multisensory, enjoyable oral experience. First thing we will do is set the stage. After we have completed all of your cares, we will nest you on your side. This encourages midline awareness. It takes less energy to be on your side. It is easier for you to breathe on your side. It is also safer for oral milk drops to be given when you're on your side. Side lying will become familiar and comforting when you begin to nurse or bottle. We will give you boundaries for good positioning and to help you feel secure. We will also place your mother's scent heart near your face so you have her scent close by. We will also position your hands by your face. This helps you to organize yourself and encourages self-comforting and makes it easier for you to suck on your fingers, which enhance the whole oral experience. So the only thing left for you to do is enjoy. We will stay with you, gently touch you, observe you, and talk to you. We will place a drop or two of milk on your lips. As you lick the milk, we will offer you a swab or pacifier. You become a participant. If you open your mouth, accept, and suck, we will give you more milk, a drop at a time. If you lick but refuse the pacifier, we will just let you lick the milk, a drop at a time. However, if you don't respond, we will just let you rest. You still have had a positive oral experience. You will have an opportunity at your next feeding. From the previous slide, you can see there really are 3 ways the infant might respond. So we're just going to break that up a little bit and take a brief look at each possible response. The first response, offering and accepting, is pretty straightforward. When we place a drop or two of milk on their lips, as the infant licks their lips, we will offer a swab or pacifier. If the infant opens their mouth and accepts, we will give them the pacifier and give more milk slowly, a drop at a time. Very straightforward. The second response could be offer and refuse the pacifier. We always start out the same. We place a drop or two of milk on their lips. As the infant licks their lips, we will offer a swab or pacifier. But if the infant refuses, thrusts his tongue, or does any aversive action, we will remove the pacifier or swab However, since the infant did lick the milk, we will let the infant lick milk drops slowly, a drop at a time. This happens a fair amount and it really does work well. And usually the infant will eventually take its pacifier, but we want it again to be his choice. The final response may be, the final response may be no response. Some infants may have their eyes closed after cares and they may appear to be sleeping. The hope is to still give these infants an enjoyable oral experience. We will still place a drop or two of milk on their lips, and surprisingly, many of these infants will respond. So at this point, let the infant guide you. However, if the infant remains asleep or does not respond, we will let him rest. Even those few drops of milk on his lips gave him an enjoyable oral experience, and he will have an opportunity at his next set of cares. As you mature, you begin to associate hunger with eating. You wake up before feedings, active, alert, and waiting. Now, when you taste the milk and we offer the nipple, you start to root. Rooting is important because it sets the stage for correct tongue position as you begin to suck. You have been practicing and enjoying for a long time. Finally, when you are allowed to nurse or bottle, it is all very comforting, all very familiar. You are on your side, our gentle touch, sucking and swallowing. You know exactly what you are doing. So how about we take a step back and look at the research we found regarding the safety of giving milk drops. Rodriguez and al. Launched a pilot study to show the safety of giving colostrum orally. They also measured the infant's immune response in their tracheal aspirates and urine. The subjects were extremely low birth weight infants with a mean weight of 657 grams and a mean gestational age of 25.5 weeks. The method was started at 48 hours of life, and the infants were given 0.2 mils of colostrum every 2 hours for 48 hours. The results were wonderful. All the infants did complete the protocol. There was a wide variation in immune response. Oxygen saturations were stable or even increased during the protocol. There were no adverse effects, and all infants sucked on their ET tube while receiving the drops of milk. Montgomery et al. Then replicated Rodriguez's research to test the feasibility and safety of giving oral milk drops. Their research did quantify the feasibility and safety of Rodriguez's study. So based on this important research, many NICUs throughout the country have implemented breast milk swabs to be used routinely as oral immune therapy and as part of their VAP bundle to prevent ventilator-associated pneumonia. But are breast milk swabs for oral care really enjoyable? The mouth is the infant's most sensitive organ and the one in which the infant has most control. When we insert a swab or pacifier in an infant's mouth, this is a form of invasion. Infants must be given control over their mouth in order to trust us. When we place a drop of milk on the infant's lips and offer a swab or pacifier, we are asking for their permission. If they root or open their mouth in response, they are accepting. They are participating. It was their choice. They are in control. The most wonderful result of this project is milk drops became a natural progression to cue-based feedings. as the nurses gave the milk drops, they taught the parents the importance of giving the milk a drop at a time. They taught the parents to let the infant guide them, to observe their infant's cues, allowing the infant time to start, stop, and restart. The stress and anxiety of starting oral feeding has changed to a calmer, more relaxed time. Parents understand now that their infant is in charge, and enjoyment is really the most important part of this. Milk drops is a simple, no expense intervention. The infant's response to milk drops is documented with every set of cares in our electronic medical record. Our medical team often includes the response of milk drops when assessing for oral feeding readiness. Our doctors have really embraced this intervention. It is not unusual for our extremely low and very low birth weight infants to go home at 36 to 37 weeks, some even exclusively breastfeeding. These parents are ready. They know their babies. There is less fear and more smiles as our families walk out our doors. So let's take a quick look at the results of our milk drop study. The major findings of our study was length of stay. If you remember, that was our hypothesis, that the infants who received milk drops would have a shorter length of stay. The first column shows the gestational age of the infants, but the most important data is column 3 and 5, which is length of stay. As we look at the groups, for example, the 24-weekers, the length of stay at the subject length of stay, mean length of stay was 90 days. And for the 24-week control, the mean length of stay was 135 days. That is 45 days difference, or 1/3 of their hospitalization time was cut off. The 25-week group is similar with a difference of 41 days. And as we go down the line, you can see that all of the categories have a shorter length of stay except for the 31-weekers that are highlighted in red. And we were actually really happy with the results of our study, but we were kind of wondering if there was a reason why this group had a longer length of stay. So we looked for outliers in the subject groups and did find that in the 31-week group, there was an infant who stayed for 70 days. And then also in the 30-week group, there was an infant who stayed for 60 days. Both infants did stay in the study and in their respective groups. And of course, we were still extremely happy with the results of this study. This slide looks at the incidental findings of cost and savings. The top chart looks at cost, and we knew that according to the major finding that our cost should be less, and of course that chart does show that the subject's costs were. However, when we looked at the savings, that helped us to see how well we really did. And as you can see, our NICU had an estimated savings of over $663,000 on these 99 infants. And as you can imagine, the hospital and our medical team were extremely pleased with these numbers. This experience has been so interesting as both parents and nurses can see the difference milk drops has made to these premature infants. We thought you might like to hear some of their comments. First, we're going to go over some of the comments of our parents. The dad of a 24-weeker, now 35 weeks, says, "I love to watch him take his milk drops. His oxygen levels are at their best when he is getting those drops of milk." The mother of a 32-weeker said, "When my baby was first born, she sucked on her pacifier, but then started to refuse it. Since getting milk drops, she loves to suck again. The mother of a 31-weeker says, I like it that my baby is enjoying something orally every time she is being gavaged. Now she wakes up early before her feedings and calms right down as she receives her milk drops. Then the mother of a 25-weeker, now 32 weeks, says, when my baby kangaroos, she is not happy until she is cradled at my breast. I know the milk drops are a big part of this. And then finally, the mother of 27-week twins, home at 37 weeks, said, my babies are coming home exclusively breastfeeding. This is just what I had hoped for. We also did a quick survey of some of our nurses, and I thought you would enjoy their thoughts. You remember our medical team from the very beginning requested milk drops become a standard of care. Our nurses and doctors have embraced this, and their support of this project was amazing. Here are a few comments from them. Some preemies are very hard to console. They cry, become apneic, they brady, and then desaturate. This activity is stressful for the baby, parents, and nurses. Not to mention, how many calories are they using? Milk drops help these infants calm. And to be honest, it helps the nurses calm too. I thought that was funny. Another nurse told us, I started to work in this NICU after the milk drop study was over. Initially, I felt milk drops probably was just an optional thing to do. Now I know how important they are, both as immune therapy and for oral enjoyment. So now I pull up all my feedings and all my milk drop syringes and label them at the beginning of the shift. So if I get busy, they're easy to grab and I won't be tempted not to give them. I thought that was very intuitive of that young nurse. One nurse mentioned, isolate sometimes feel like a barrier to parents. Milk drops give the parents a reason to go beyond that barrier, to spend time with their infant, talking, smiling, touching. It is really fun to watch them enjoying being parents. Another nurse commented that she gives milk drops while mothers are doing skin to skin. She said even if only a drop of milk is given, it helps the infant to associate oral enjoyment with his mother. I thought that was an excellent comment. So finally, one nurse really wanted me to make sure I explained that milk drops are not just for preemies. This nurse was assigned to take care of a full-term infant with PPHN, vented on high settings in 60% oxygen. The infant was on dopamine and fentanyl drips and receiving additional sedation every 2 to 4 hours for agitation. After milk drops were started, began to rest 3 to 4 hours at a time with no additional breakthrough sedation needed. She says, we were able to wean the ventilator and answers. This was a completely different baby than the night before. The nurse also mentioned the mother's response. The mother said, I know the doctors and nurses are helping my baby, but sometimes, even when I'm in the room, I feel I am watching from a distance. Even if I am not physically giving my baby the milk drops, I still feel involved. I can see it calms my baby. I truly am doing something to help my baby. So now we're going to just take a few minutes and watch some of these little preemies in action. So this first video is of 2 micro preemies. Both are fun to watch. This first little guy is 26 weeks corrected. I just gave him a drop of milk. As he licks the milk, I stroke his lips with a swab, and he opens his mouth to accept. I give him time to suck, and then give him another drop of milk. It is so important to be patient, to go slow, and let the infant guide you. This second little guy is also 26 weeks corrected. He is ready for his milk drops. His cares are all done. He's on his side. His hands are by his face. His mama's scent cloth is by his face. He is ready. I just gave him a drop of milk, and as I get the swab ready, he opens his mouth and then starts sucking on his ET tube. I stroke his lips to encourage him to take the swab, but he is busy sucking. So lesson learned, moisten the swab before giving the milk drops. This second video is a beautiful little girl who always loved her milk drops. I give her a drop of milk and offer her the pacifier. As you stroke the pacifier against her lips, it may be kind of tempting to insert that pacifier, but give them time. Let them accept and enjoy. I bring her hands back to her face to help her stay tucked. As I hold her, I gently talk to her. Every sense is engaged, wiring and making connections. Same little girl, a little more active now. I give her a drop of milk and offer her the pacifier. As she accepts the pacifier, she calms down but remains alert. She now sweetly brings her own hands to her face as she sucks. Can you see how she is relaxing? Even her breathing is slowing down. Same little girl at 34 weeks, ready and waiting. I give her a drop of milk and offer the pacifier. So cute. There is no hesitation as she pretty aggressively roots. This is so great to see. As she accepts the pacifier and starts to suck, she calms down and again brings her hands to her face. This is all very comforting, all very familiar. This final video is the result of giving all of those milk drops. This little guy is active, alert, rooting, and ready to eat. As soon as he accepts the nipple, he brings his hands to his face. He becomes organized and slows down nicely to suck. And this truly is my favorite slide. It shows a brief history of what can and did happen to one of our micro preemies. We are not always privy to the outcomes of our babies after they are transferred to another hospital or when they go home. This little girl was born at our hospital, and her mother wanted us to share her story. Parker was born at 23 weeks. On day of life 3, milk drops were started. At 28 weeks, after several rounds of medication to close her PDA, she had surgery to ligate it. Even so, her chronic lung remained severe, and at 35 weeks, she was transferred to a level 4 NICU. Her mother did advocate for her and requested the new NICU continue milk drops, which they did. At 52 weeks, 17 weeks later, although still on RAM CPAP plus 6, Parker was offered her first bottle. This is unusual, but I think they wanted to let her try. The nurses were amazed at how well she did. At 54 weeks, just 2 weeks later, she had progressed to demand feedings. At 56 weeks, she was discharged home on nasal cannula on full oral feeds. No one thought this would happen. At 58 weeks, which is even more unusual, speech therapy signs off. Parker is doing great. However, after 18 weeks at home, at 17 weeks corrected gestational age, our little girl comes down with viral pneumonia. Initially intubated and in the PICU, the doctors decide she needs more help, she needs ECMO. And this would allow her lungs to rest and heal while letting the virus run its course. The good news is this little fighter, after 4 weeks at home or 4 weeks in the hospital, is back home. This picture makes me so happy every time I see it. Here is little Parker relaxing at home in her boppy, holding her Dr. Brown bottle with her feet. This was such a wonderful family and such a wonderful outcome. They are just doing great. So, as I have gone to conferences, there are some frequently asked questions that I might address first. And then after the webinar, we will still have time for any questions you may have. So the first question is oral immune therapy the same as giving milk drops? A lot of nurses come up to me and say they feel they are doing what we are doing. But I explain oral immune therapy is usually considered oral care. As we discussed earlier, many hospitals include oral swabbing with breast milk as part of the oral immune therapy of their VAP bundle. However, milk drops are for oral enjoyment and are meant to be given after all cares are completed. So really the only thing left for you to do is give the milk drops and spend time with the infant. I like to think of it as this is the last thing the infant will remember, the smell and taste of his mother's milk, as well as our gentle touch. So the second question is, do you only give plain breast milk for milk drops? Plain breast milk is preferred mostly because we're not for sure how the fortified milk would taste to the infant. But if there is only fortified milk in the refrigerator, we will use that, of course. So number 3, would you give formula for milk drops? Our NICU has a standard of care that premature infants are given either their own mother's breast milk or donor breast milk up to, I believe it is 34 weeks. Parents sign consents for donor milk. However, we do use formula if the mother does not want donor milk or there is a reason the infant needs to take formula, such as milk protein allergies. Oral enjoyment and the connection to eating is the goal. The last video of the baby bottling was really actually a formula baby, the little guy who was rooting and just really enjoying his bottle. The fourth question is, what if an infant is NPO? It is up to the doctor to decide if the infant may continue to receive milk drops. The doctor will write an order to clarify this. And it's so interesting. Parents are such big advocates for milk drops that they sometimes daily when an infant is NPO will ask the doctors on rounds if their infant can start taking their milk drops. So I think this is so interesting, and I think the parents really enjoy the milk drops for their babies and understand how important they are. Number 5, do you give milk drops with oral attempts? Well, I have used milk drops to help an infant to latch on when attempting to nurse. However, routinely, nursing and bottling are the enjoyable or are the oral enjoyment for that feeding. So usually I do not give milk drops with oral attempts. Number 6, do you start the gavage feeding before giving milk drops? Yes, everything should be done so that I can spend time and focus on the infant. It also allows the infant to associate the comfort of becoming full and being satisfied while he is receiving the oral enjoyment of milk drops. So one nurse, it was a nurse, asked how long would this intervention take? So I explained it depends on the infant and their response. It's so important, and I stress this, to be patient and give the infant time to respond, time to start, time to stop, and even time to restart. Sometimes there's a pause between when they restart sucking again because they can't become so calm. But this is the wonderful part of it, is they are just enjoying this whole time. Especially the little micro preemies, they need that time. Surprisingly, most of these micro preemies do respond and enjoy the milk drops. It will pay off. As time goes on, these little ones will be awake and waiting for you. However, I do know as a bedside nurse, sometimes you are busy, and so busy that you may think, I don't have time for this. So I would encourage you to pull up your milk drop syringes ahead of time so they are easy to grab. And then even if you can just give them a drop or two of milk, it is still an enjoyable oral experience. And I would also maybe encourage you that before you fortify your milk, maybe get those syringes pulled up so you have the plain breast milk to give them for milk drops. But again, you can use fortified milk. So I wanted to kind of go over some implications of for research. Also at the conferences, I have met with some incredible NICU professionals. I've spent hours with them discussing how milk drops could help premature infants. And I would like to share a few of these researchers' perspectives. I have had several researchers discuss replicating our study with a larger sample of infants. This is very exciting, and we do hope to partner with them to move this forward. And then there were several other researchers that discussed the possible theories to research. One researcher discussed the hypothesis of the possible effect of giving milk drops and reflux. She explained that as the infant is maturing and growing, the very premature infant is only swallowing saliva, and he has usually a feeding tube that goes directly into his stomach. She continued to state that milk drops given consistently with gavage feedings is truly engaging the esophagus and cardiac sphincter. As the infant sucks and swallows the breast milk, the esophagus is also being bathed with immunoglobulins. She cited a 2013 review of non-pharmacological management of gastroesophageal reflux, which discussed body positioning, feeding strategies, as well as non-nutritive sucking. Non-nutritive sucking in itself is controversial in that the act of swallowing elicits the cardiac sphincter to relax, but at the same time, the act of swallowing also promotes the esophagus to clear the reflux. She hypothesized that milk drops may enhance the effect that non-nutritive sucking has on reflux. So I thought that was very interesting. Another researcher came up to me and discussed the slide that states 40 to 70% of very low birth weight infants will have later cognitive, behavioral, and social delays. She talked about a study that looked at the concern of infant isolation, that premature infants may spend months in the NICU during a critically important developmental period, which may have long-term physical, psychological, and neurodevelopmental outcomes. The results of this study found that preterm infants cared for in private rooms had reduced cerebral maturation at term, as seen by MRI and EEG, when compared to infants cared in an identically managed open bay unit. The study hypothesized that the findings may be explained by the sensory and social deprivation of these infants in private rooms. As we discussed this study, we both acknowledged that NICU nurses are taught to get in and get out. In other words, take care of what you have to do and let the baby alone. This is really not meant to be mean. This is meant to prevent overstimulation and allow time for the infant to calm and rest. However, in utero, the infant is communicating with his mother and being comforted by her touch and sounds continuously. At birth, that connection is removed. The researcher then hypothesized how the milk drop intervention allows the very premature infant to be engaged with his mother again through the smell and taste of her milk, while also giving the caregiver permission to stay with the infant, to touch him, and to talk to him. This gentle social interaction given consistently around the clock is also wiring enjoyable social neural connections that could possibly make a difference to these infants. Milk drops may very possibly help premature infants in many ways. So you might be asking, where do we go from here? Some hospitals have made milk drops a quality improvement project. If you feel you would like to start breast milk drops in your unit, the great news is you have this Dr. Brown webinar that you can send to your stakeholders to help explain the rationale, research, and great testimonials. I also do have a packet that I can email to help you get started with our standard of care, our routine order set for milk drops, and how it looks on our EMR. So please feel free to email me, and in the subject line, please put milk drop information. And my email was at the very beginning of the webinar. So anyhow, finally, I want to say a special thank you to Unity Point Health Des Moines. Our institutional review board was so excited and so supportive of this project. They were just almost giddy when when we first started it, they loved it. And when we ended it, they loved it. So that was wonderful. And then our research committee, who did so much work on this project, Dr. Linda Brady, Lucinda Butler, and Cherie Tilton, they were amazing. They did so much work, and I truly appreciate that. And then all of our nurses and staff at Blank Children's Hospital, NICU, for all your time and effort, I do want you to know that it's not been unnoticed, and I so much appreciate you. And thank you so very much.